That's why I ask people.
All right, you guys ready? Yeah. All right. Let's talk about ASD. Right. So your ASD or atrial septal defect is a defect where? Between your atrium, right, and that septal wall, right, from left to right, shunting. Okay. All right. So what signs and symptoms are you going to see? Well, for a lot of our kiddos, they might be asymptomatic, right? So if that hole is very small, or that defect is small, they're going to have less symptoms. Okay? The bigger the hole, the bigger the issue, and then we might see some of these other signs and symptoms that go along with that, right? You're definitely going to hear a murmur, right? What is that murmur going to sound like? Like that, right? It almost sounds like a washing machine cycle where it's doing that whoosh, 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 right? Where the little thing in the center is going back and forth, right? Agitator, thank you. See, I forget the words.
You know what it's
you fill it in.
Because the old school ones with the
Yeah, the thing with the tower in the middle, right? Yeah, because it's forcing the higher clothes to like actually move.
You'd be surprised what us millennials do.
I'm a millennial.
The only problem is you can't wash as many clothes at a time because the agitator takes up too much space.
Oh, sorry, it's the people that go from Gen X to millennial.
I'm like, are you?
No, I'm actually like right on the board.
Heart failure symptoms, right? Fatigue, poor growth, right? So as they're, if they're not perfusing well because of this defect, it's not going to take them much to get fatigued. And when they're feeding, they're burning through what oxygen reserves that they have, right? So we're going to see that they maybe only make it through like 5 minutes of their feeding, maybe 10 minutes. They're not going to get through their whole feeding before they completely tire out, and they don't want anything to do because they're so tired.
My daughter would fall asleep on the
Yeah, they just fall asleep, right? Because it takes so much energy for them to feed that they are burning through their oxygen, and then they just give up, right? And then they choose to breathe over feeding. So one of the things that we can do is decrease the amount, increase the calorie, right? So add that powdered formula to the ready to feed. However, that is going to be dietitian specific, right? They are going to evaluate the child. They are going to tell you how much to feed. So the total volume, how much you have to add to it, what amount of calories you're going to get to by making that mixture, right? We can see that they have some recurrent respiratory infections, and it could lead to atrial arrhythmias later in life, right? Why might they have atrial arrhythmias later in life? They might even have them now, right? Why?
Is it because the signal is
Yeah.
having to go around the hole?
Yes, the defect is right where that electrical pathway goes, right? So we might see that they have it now, depending on how big that defect is, or they might have it later on in life if there's You know, if that area starts to kind of wear down and affect that electrical pathway, right? So, what does that mean for us? What are we going to do as far as our nursing interventions? Well, the first thing that we're going to do is monitor for signs of heart failure, right? So, what are we going to look for? Edema, crackles, waking, right? We're going to look at their eyes and nose. What's going in? What's coming out? Are they putting on weight? And do they have edema? Absolutely. We're going to assess for those murmurs and heart sounds. So when we auscultate and we're listening for one, really it's only within our scope to say this child has a murmur, right? Not necessarily which one they have or the degree of which one they have. That is physician, right? They will listen to it, they will diagnose it, and tell you what degree murmur they have, you know, what type of murmur they have. Because some, like, you can tell which one they have because of where you're hearing it, right? So obviously your ASD, you're gonna hear a little bit higher in the heart, right? And your VSD, you're gonna hear it lower, just because
It's
like,
this big anyway.
depending on their size, your stethoscope might cover both of them, so it's really hard to hear where it's at, right? But have you seen the NICU stethoscopes? They are literally like smaller than a quarter, right? So even though their hearts are really small, you're just gonna have to get a smaller stethoscope and you'll be able to hear it a little bit better, right? But like your gigantic like cardiac one for adults is going to cover their entire heart, right? Sometimes, depending on their size, you might even be covering a portion of their bowel because of how big your stethoscope is, right? And how small they are. So definitely making sure that wherever you're at, you have the stethoscope that's appropriate for the patients that you're listening to, right? The smaller they are, the smaller the stethoscope, okay? We're gonna give those diuretics as prescribed, right? Because if they're in heart failure and they've got edema, we want that fluid to come off, right? If we pull that fluid off, is that gonna help them breathe a little bit better?
Yeah.
Yes. Is it gonna help them move around a little bit better? Yes. Because they can breathe better, right? Promoting adequate nutrition and growth. We talked about that, right? Decrease the volume, increase the calories. Educate parents on the signs of complications. What complications might arise from ASD? Failure to thrive, maybe some hypotension, right? Activity intolerance, right? Maybe they're not running around as much as they should, right? If they're gonna go in for surgery, you're gonna provide that pre and post operative care, just like we talked about, right? What are they gonna look like? What are they gonna have? Right? What monitors are they gonna be on? Right? What are we looking for? We're gonna monitor those atrial arrhythmias. Those are gonna be lifelong, especially after closure. Why? We already talked about it, right? It affects that electrical pathway. Just that surgical procedure alone could disrupt that pathway even more than it already is, right? So we always wanna make sure we get an EKG before they do it and one after, right? Because we wanna compare, was there any sort of electrical pathway change during that intervention, okay? For ASD, strenuous activity only needs to be avoided for about 2 weeks. Why? Yeah, right? For VSD, it's a little bit longer. It's like 6 weeks. Why the difference between the two? Why only 2 weeks for ASD and like 6 weeks for VSD?
Are they able to go in?
Less pressure.
Less pressure, right? It's not as strong, right? The force of the contractions isn't as much as it is with the ventricle, right? Because your ASD is really only pumping, or your atrium are only pumping to where? To your ventricles, right? So it's really only pumping to right here, where your ventricle is pumping to where?
Everywhere.
The whole body, right? So you think it's gonna pump a little bit harder? Yeah, hopefully,
Just a
right?
smidge.
Or we're gonna give some meds to pump a little bit harder, right? But it should pump a little bit harder. So for ASD, recovery is only about 2 weeks, okay? So what are some implications that this means for them, right? They're often asymptomatic in childhood. Again, the smaller the defect, the smaller the issue. Bigger the defects, more issues that we're gonna see, right? Risk of pulmonary hypertension if unrepaired. How is that going to happen if we don't repair it? How are they gonna get that pulmonary hypertension?
But it's black back into the right one.
Yeah, because we're pumping more into the lungs, right? Because it's going from left to right, so we're going from the left atrium to the right atrium, and then right atrium down to the right ventricle and back to the lungs, right? So most of where it's going is going back into the pulmonary system, so it's just backing up there, right? Some of it is getting down into where it needs to go to pump back out, okay? But not all of it, okay? They run a risk of atrial arrhythmias and increased risk of stroke later in life. Why? Clots, right? If that atrium isn't pumping right and it kind of starts to flutter or like fibrillate, right? That's going to put them in an increased risk for stroke, right? Okay. Requires lifelong follow-up even after repair. They're always going to follow a cardiologist.
For like test purposes, if we do get like an image or anything like that, would it be something like similar to that? Or if we
You're not going to get an image.
Okay.
We weren't gonna get an image.
Now you might get an image.
Which way flows?
There are currently no images on your test, but that's not a bad one.
Okay, but if you did, it would be like obvious, like what's going on.
Yes.
Okay. Like,
Yes.
it's
Yeah.
already like
So so obviously I wouldn't have defects and this wouldn't be up here. It would just be a picture of this and it would say, what defect is this? Right? Based on the blood flow of this defect, what defect is it? Right? Or something like that.
We want to give him an idea that we don't like the idea.
Wait, so when they go to school, what do you tell them?
What?
Can they, like, will we have to tell the people that learn something at the school?
It's like,
Are they, cause they gonna be on, really giving the medication? Cause they gonna.
Yeah, they probably won't take any medications at school. They'll probably take them like before school and then so they're usually like twice a day, like once in the morning, once at night. So they probably wouldn't have to take anything. For the 2 weeks that they're recovering, they're probably just gonna be at home. Because we don't want them like doing long walks or like going up and down stairs and stuff like that. Like we just really want them super chill and nothing that's gonna like excite them, right? Okay. All right. What do you know about VSD? Where's this defect? The hole in the septum between the ventricles, right? Again, going left to right. Okay. So this again is a acyanotic defect, meaning blood is going through the pulmonary system, and so it's getting oxygenated. So what is going out to the body is oxygenated, right? It's just oxygenated blood is just going back through the pulmonary system, just making sure it's like extra oxygen, right? Like 6-7 times. Okay, so what are you gonna see? What are you gonna hear, right? Well, you're gonna hear this loud, harsh, holosystolic murmur. So essentially from S1 to S2, right? It's gonna be from S1 to S2, you're gonna hear this whoosh, 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 whoosh. It's gonna sound very similar to your ASD. It's just the location is gonna be down over the ventricles, right? Okay. Same signs and symptoms we're gonna see: heart failure, poor feeding, poor waking, fatigued, recurrent infections, diaphoresis during feeding, right? So very similar to your ASD, just a little bit more intense because of where it's at, right? So what are your interventions? Are they pretty much the same as your ASD?
Yeah.
100%, right? If they've got signs and symptoms of congestive heart failure, we're gonna treat it. If we need to make their pump work a little bit harder, we're gonna give them some meds to make their pump work a little bit harder, right? Contract a little bit better. Educate on the complications, provide that post-operative care, monitor for arrhythmias, right? Same thing with ASD. It is right where the electrical pathway goes through, right? So the bigger the hole, the bigger the issue, right? So if they've got arrhythmias, we're gonna do EKGs, right? We wanna make sure that those electrical pathways aren't changing. If they're gonna go in and they're gonna do a surgical procedure, we're gonna do one before, we're gonna do one after. Same thing with the ASD, right? They're very, very similar, okay? Many of them close spontaneously, just like with ASDs. A lot of them close spontaneously. Most of the time we don't have to do anything. And if they're not causing an issue, we're just gonna let them be and just monitor, right? It's not until they become an issue that we really wanna intervene, okay? We don't have to go in and do a surgery. Are we going to avoid it? Yeah, why put them at risk for something that that isn't causing an issue right now, right? Larger defects can lead to pulmonary hypertension, right ventricular hypertrophy, and heart failure. So one of the things that can happen with VSD is that we get right ventricular hypertrophy, meaning the right ventricle, because it's working so hard to overcome the pressure from the left side, that it gets stronger and eventually will overcome the pressure on the left side, right? The heart is a muscle. What happens when you work out a muscle? It gets bigger, it works harder, right? And it becomes stronger. So what happens when the blood flow now flows from right to left?
You're sending deoxygenated blood to the body.
You're sending deoxygenated blood to the body. So VSD can become a cyanotic disorder if left untreated, right? That is called Eisenmenger syndrome, where the right ventricular pressure overcomes the pressure on the left, and now it's shunting right to left and sending deoxygenated blood out to the body. So then we're gonna see they look what?
Blue.
They look blue, right? Absolutely. Okay. What do you know about your PDA? Well, this is a fetal circulation structure, right? It's going between the aorta and the pulmonary artery, right? For circulation, because that piece in fetal circulation is essentially bypassing the pulmonary system, right? So it's a structure there that they need during fetal development, but we don't need it and don't want it after birth, right? If it is the only defect that is happening, we want it to close, right? So it is a right to left, or left to right shunting. So it is an acyanotic disorder, right? Because it's sending things back to the pulmonary system, right? We want it closed if it's the only defect. If it is present in tetralogy of Fallot, which it should be, it is one of the defects, we want it to stay open, okay? So let's talk about this just on its own, and then we'll get to tetralogy of Fallot, and then we'll talk about why we don't want it, or why we do want it, okay? So what are you gonna hear, what are you gonna see? So when you auscultate the heart, you're going to hear a continuous machine-like murmur, right? So with ASD and VSD, I said that it sounded kind of like a washing machine. This is different. Your washing machine, there's a start and a stop to the whoosh, right? It's whoosh, 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 whoosh. This is like you walked into a machine factory and there's just machines going all over and there's no like start and stop to it. You just hear this very harsh murmur that shouldn't be there, that is continuous.
Does it still sound like this whooshing kind of noise, or?
No, it's very loud and very machine-like. It's, let's see, do I have, is there one in the Nearpod? Did I put it there? See how there's not like a very distinct like start and stop. It's just kind of like rolling to the kind of rolling into the next one, right? So you're just kind of
Yeah.
almost like you're hearing an artifact,
That doesn't sound
right?
like wind.
Yeah. Whereas so this is your VSD. See how there's like a very distinct like start stop.
I can't hear the switch as much enough. I mean, I hear the one, it sounds like.
Did you hear it? Okay, this'll help. So this is where, okay, so when you're listening to the heart, really you're listening in like these 4 locations, right? So this location here is where you're going to hear the VSD, right? So kind of visualizing where it's at so that you can kind of tune into that one at that point, I think is gonna help. So where it got much louder in that location, it had that like whoosh, 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 whoosh right there. Sorry, 1 second. So the screen is cold. Hello.
That's my feeling, but also I don't want it to be that,
It's nice having a spouse here. Okay. Feel pretty good with that?
Yeah.
Okay. All right. So, with your PDA, again, we've got that continuous murmur. There is a wide pulse pressure and bounding pulses. We've got, you can see tachypnea, dyspnea, poor feeding, poor waking, fatigue. Pretty much the same signs and symptoms that you're going to see with ASD and VSD, right? Because they're all causing the blood to go in the same direction, so you're going to see the same signs and symptoms, right? This is just a different way of essentially stating the same thing that was on the previous 2 slides, right? So, our interventions, are they going to be this pretty much the same thing? Yeah, right? With a couple of different things. With PDA, you will find that they have bounding pulses. Okay? With ASD and VSD, they don't change. Right? They're just normal pulse pressure, right? But you're really going to feel them in a PDA. Okay? We might administer indomethacin, right? As prescribed, and this is for our preterm infants. Okay? What is indomethacin? Do you know what drug class it is?
No, it's I know it's not too for going to waivers.
That's what? It's not an antibiotic.
It's NSAID.
Yes, it is an NSAID, right? So it is an NSAID that is very good at closing the PDA, right? So if they have it and they're preterm, they're definitely going to get it, right? Because their body is not at the point where it should close on its own. So really, your PDA is most common in like preterm infants, where they're just not, their body isn't there yet where it should have closed it on its own, right? We can give them indomethacin and it will close it, right? Or some form of NSAID will close it. However, what do you know about NSAIDs in infants? Their kidneys can't process it yet, right? So ideally, we don't want to give an NSAID to an infant who's less than what? 6 months, right? But if we need to close that PDA because it's causing issues, it's one of those risk-benefit things, right? So we talked about, or we will talk about in Kawasaki's, we actually want to give aspirin for that disease process, right? But otherwise, aspirin is 100% not given to kids, right?
Yeah.
It is the only time they will get it in Kawasaki's because that risk benefit of, you know, them getting Rye syndrome versus actually treating the disease process is what we want, right? Okay. Same things when it comes to education, right? Nutrition. We're gonna educate on, you know, how can we promote that nutrition? What are they gonna like pre and post procedure? What we're gonna monitor for. The monitoring for PDA actually changes just a little bit after the procedure. In here, we're gonna monitor for bleeding and laryngeal nerve damage. Why?
They go down instead of in.
They do. So because of where the PDA is, it sits very close to that laryngeal nerve, right? So what are you gonna see if they damage the laryngeal nerve during that procedure? Maybe spasms. What does our laryngeal nerve do? What does it innervate? Helps you to talk, helps you to swallow, right? We're gonna see that they might have issues with feeding, that their voice changes, right? Or their sound changes, right? So we wanna make sure that we're checking for those and assessing for that. It's going to lead to some of the same things. So pulmonary hypertension, heart failure if uncorrected, right? Because of where the blood is flowing. Risk of infective endocarditis. That is, you know, because of the procedure really, where they're going in, right? Spontaneous closure may occur in term infants, and it should, right? It is a structure that once they start breathing and that pressure in those vessels changes, it causes that to close. So most of them will close on their own. Really, we're looking at it again, mostly in preterm infants, okay, where they're not there yet. The procedure that they're gonna have is a surgical ligation or catheter-based coil embolization. So that, again, they're going to go in via the catheter route instead of doing like an open heart, and they're gonna close it that way, okay? Requires lifelong follow-up if uncorrected or after intervention. Even though it's outside of the heart, we're not really necessarily affecting anything as far as like the surgical pathway because it's not inside the heart, but it is still a heart procedure, right? So they're still going to be followed by cardiology, right? We want to make sure that that's correction, they're not having issues with it, okay? All right, so what do you know about coarctation of aorta? Does this happen inside the heart or outside the heart? Outside the heart. Okay. It is a narrowing of the ductus arteriosus, reducing lower body blood flow and increasing upper body blood flow. Right? So this is where it's happening, right? These vessels feed the upper part of the body. Okay. So what signs and symptoms are you going to see in your kiddo with coarctation of the aorta? What happens when you take their vital sign? Their blood pressure is going to be like sky high in their upper extremities and almost non-existent in their lower extremities, right? Because they don't have good blood flow down there, okay? When you're feeling for their pulses, what are you going to feel? Bounding up here and almost like faint or non-palpable in the lower extremities, right? So how are you going to know if they have blood flow to the lower extremities? What are you going to do?
pulses.
What if you can't feel it? The Doppler, right? We're going to use the Doppler to see if there's blood flow. We can use that if we can't palpate their pulse, right? We'll use the Doppler to see if there's blood flow there. Okay. When it comes to their temperature, what is the temperature difference going to be? It's going to be warm up here and cold down there, right? Every husband's worst nightmare: cold feet. Right? They might also look very pallor in their lower extremities too, right? And kind of maybe red and flushed in their upper extremities with all of that blood flow. So it's gonna be nice and warm versus nice and cold, right? You might also see that they come in, if they're able to tell you, they have a headache, they've got bloody nose, they're dizzy, right? Why are they gonna have all of those symptoms?
So much pressure.
Because of all of that pressure up there, right? All of that pressure that's going up there is going to cause them to have nosebleeds, they're going to be dizzy, headache, they might faint, right? Okay. Our headache, what if our infants can't tell you they have a headache? How are they going to present? Crying, very irritable, right? Almost like non-consolable. Right? If they've got a headache and they're just crying, everything that you do isn't going to help them unless you give them some pain medicine, right? Even with that, they still might hurt quite a bit. So when it comes to our nursing interventions, what are we going to do? Check their blood pressure on all of their extremities, right? So our vitals are always number one, right? Check their vitals. What is their blood pressure? What's their oxygen like? Our biggest difference that we're going to see between the two is going to be our blood pressure, right? Again, sky high in the upper extremities, virtually non-existent in the lower extremities, right? Okay. You're going to assess and compare pulses, right? We talked about that, bounding in the upper and faint in the lower. Do you think they're going to need an antihypertensive? Yeah.
Would you have them try and do more standing, or not try and avoid laying flat?
Definitely avoid laying flat, so you'd still have them elevated for sure. But you really don't want them up and out of bed, especially if they're going to be fainting. Right? Yeah. So just elevate a little bit and then pretty much bed rest until we get it fixed. Monitor for signs of heart failure. Again, the blood flow, right? Circulation is going back into the lungs, right? So we're going to see that it's backing up a little bit, right? Same education. What complications are they going to have? What activity restrictions? What are we going to monitor for? What are they going to look like before and after surgery? Okay. So what does this mean? It can lead to hypertension, right? We know that. They've already got it, right? Because it's much higher prior to the surgical procedure. Stroke, aortic rupture if untreated, right? We are putting so much pressure on that aorta, right? There's a lot of pressure in the aorta in general, right? Because we're trying to pump everything out to the rest of the body. But now you've clamped it down, where's all that pressure going? Right behind it, right? So we're applying more pressure to a very tiny, narrow opening. It could rupture there, right, with all of that pressure. Okay. How are we going to fix it? A vulvoplasty, right? They're going to go in with a balloon and they're just going to pump it up and fix that stricture, right? Okay. There is a risk of recoarctation or aneurysm following post-repair, right? So it could clamp back down again if they don't fix it well enough, right? So we want to make sure that we're monitoring for that.
Would they be able to also just put a balloon and then a stent to keep it?
Probably. Yeah. And then lifelong follow-up, including blood pressure monitoring, right? We want to make sure that over time it's not clamping back down again, okay? Or that if they did put a stent in, that isn't failing. Okay. All right, let's talk about tetralogy of Fallot, right? What do you know about tetralogy of Fallot? First of all, let's break down the word tetra. Tetra meaning what?
3 places.
4.
Oh,
4. There are 4 defects, and they are very specific defects. It's not just 4 that you throw in there and call it tetralogy of flow. There are 4 very specific ones, and they have to have all 4. They can have more on top of that, but they have to have those 4 in order to be tetralogy of flow, right? So this is a VSD, pulmonary stenosis, overriding aorta, and right ventricular hypertrophy. So what does it mean to have an overriding aorta?
that the aorta is bigger than
It's bigger than it should be, essentially, and it has moved position. So with all of these defects that are happening, it actually changes the shape and location of the heart in the chest, and it kind of moves it and tilts it a little bit. So when you look at an x-ray, it's more like boot shaped on the x-ray, right? Instead of kind of just its normal location. And the cause of that is the right ventricular hypertrophy pushing the heart over. Okay. So this is a cyanotic disorder because blood flow is mixing with deoxygenated blood, and that is what's going out to the body, right? So you've got blood coming into the atrium, right, and down into the right ventricle, but there is right ventricular hypertrophy, so this blood is deoxygenated, yeah? So if it's going over here, where's it going? So from the left ventricle, it goes where? To the rest of the body, right? So if you're sending deoxygenated blood to the left ventricle and out to the rest of the body, what are they gonna look like? They're gonna look blue, right? So this is what makes this a cyanotic disorder, because they already have the right ventricular hypertrophy, right? Because that pressure has overcome that shift from left to right to shunt it right to left, okay? And then you have your, you've got your pulmonary valve stenosis, right? So it is not opening and closing like it should. And your overriding aorta is just that it has moved over a little bit because of the change in position, right? That's really all that means. There's no change to the aorta or anything other than it has just moved from the shift in the shape of the heart within the chest. Okay. So we're gonna see that they're blue, they're cyanotic, right? Especially during episodes where they're using, or during time frames where they're using more oxygen than just sitting at rest, right? So if they've got a crying fit, are they gonna be using a lot more oxygen? If they're feeding, are they gonna be using a lot more oxygen? Yes. So we're gonna see that during those times, they're gonna turn more blue than normal, and we call that a TED spell. They have a rapid drop in their oxygenation, and they turn blue. Okay. If they haven't had it corrected early on, and this is a child that we're seeing like in early school age, or even maybe later, if they haven't had, or if they've had like a lack of access to healthcare, we might see them a little bit later. We are going to see that they've got clubbing of their fingers, right? Because they've had chronic hypoxia up to this point, and we know that chronic hypoxia causes clubbing of the fingers, right? So we might see that. Dyspnea on exertion, right? Because if they're getting up and moving, are they using more of their oxygen supply? Yes, so they're gonna find it hard to breathe and they're gonna drop their oxygen, okay? Squatting, we talked about it, right? It increases that systemic vascular resistance, improving blood flow to the pulmonary system, right? So when they squat down, it shunts everything to that pulmonary system, right? If they stay there too long, I'm sure, you've all done it, right? You've been squatting down for a while and you stood up and you get lightheaded. Well, all the blood now can go back to your legs, right? Fatigue, poor growth, and we're gonna hear that loud murmur, right? Are you gonna hear the VSD murmur? Yes, there's a lot going on in here. You're gonna hear a lot, okay? So, what does that mean for us? What are we gonna do for that? What interventions are in place for these kiddos? Well, the first one, the biggest one, is monitor for those TED spells, right? Why is that your priority, monitoring for those? Oxygenation, right? This is huge. We talk about like our ABCs, right? It's one of the big three, circulation. They don't have a lot of oxygen going on in their circulation, right? Those TET spells, again, are a very rapid drop in the oxygen availability that they have, okay? So, what are we gonna do for them when they have one? The first thing we're gonna do, need a chest, right? Put them in that position, right? Because you can do that real quick. And then you're gonna grab the oxygen, you're gonna put that on, right? And then you're gonna give morphine, right? Why would you give morphine during a TET spell? Okay, so dilating the vessels, right? What else? What did you say, Hayden?
Calming them.
It does help calm them down, right? It's really the whole idea of giving morphine is that it relaxes the respiratory system, it relaxes them, and so that their use of oxygen during this spell goes down, right? Their demand for oxygen goes down because you have relaxed them, right? Okay. We want to make sure that we're promoting adequate hydration, monitoring for signs and symptoms of arrhythmias, right? Okay. Because they have the VSD. So what is disrupted? That electrical pathway, right? So one of the defects is right where that electrical pathway goes. We are still going to monitor for those arrhythmias, right? And again, that education, what are they going to look like? Pre-care, post-care, and how are they, before they get there, how are we going to manage those TET spells, right? We want to make sure that the parents know what to do, right? Because if they're in the room, what can they do first before we get there? They can put their child in that knee to chest position, right? That is something they can do, and then we can throw the oxygen on, we can grab morphine, and then we can go in, right? Okay, so what does this mean for them? What are some implications that go along with this? Well, this is a very complex defect, right, involving those 4 defects. Again, they have to have these 4. They could have an ASD, they could have, a number of the other ones. We actually want them, if they still have it, so if we know that a baby is being delivered that has tetralogy of Fallot, we want that PDA to remain open. Why do we want the PDA to remain open? What did we just talk about with PDA?
They have to be the only problem with the only thing wrong with it.
So with the PDA, if it is the only thing they have, we want it closed, right? It is a defect that causes left to right shunting, right? And we know that right to left shunting causes blood to go where? Back to the lungs, right? So if this is a cyanotic disorder and we are sending blood out to the body that is deoxygenated, right? Because the blood is flowing into the right atrium, down to the right ventricle. Most of it is going over to the left ventricle to go out to the rest of the body. What is it bypassing? A lot of it's bypassing the lungs, right? But where is the PDA in relation to circulation? It shunts blood back to the pulmonary system, right? So if that PDA is shunting blood back to the respiratory system, what's happening to the blood that's going there?
So these things are
It's getting oxygenated, right? So it is going to help improve the oxygenation for a kid with tetralogy of Fallot, right? So we want that PDA to stay open. What are we going to give them? The indomethacin closes it. What's going to keep it open? You said it earlier. You said it earlier. The prostaglandin, absolutely, right? Prostaglandin E1 is going to help keep that PDA open. So they are going to get on that right away, and it is going to be a continuous infusion to keep that PDA open until they can get into surgery to surgically repair the defects that are going on, right? Okay. Okay. So usually they will repair between 3 and 12 months, right? If it is super impactful, they might do some of those palliative surgeries first, like those shunts that I talked about at the very beginning, right? They might go in and just kind of create some shunts to improve the oxygenation before they actually go in and do like the VSD repair and do anything with that pulmonary valve, right? So they might do palliative stuff first just to kind of help, and then they'll do the full-on surgery later, okay? They have a risk of arrhythmias, sudden cardiac death, residual pulmonary regurgitation post-repair, and they are going to follow a lifelong cardiologist, right? If you've got a defect, you're going to be followed by a cardiologist for the rest of your life, right?
So would a blackberry be blue?
Huh?
I mean,
What did, wait, what did you just say? Did you just say what I think you just said?
I think they'll get
wait, the right way. Would it? I mean, I was looking at, I don't see the.
Like,
How would we turn it if you're dark skinned? How would we know if you don't? Are you gonna be blue?
Yes.
No, you're gonna be green.
Yes. So, where do you have lighter skin?
Oh, just like.
Palms on your hand.
The palm, usually the palms of your hand, their hands are a little bit lighter, palms of their feet, their mucous membranes, right? Like their eyes, right? So there are areas that even though you might have like super dark skin, we can still tell that you're cyanotic by looking in those areas, right? They will turn cyanotic, you will see those changes. It is a little bit harder. You definitely need to know where to look, as well as like the manifestation of all these other symptoms, right? If your child is like displaying these signs and symptoms, where do you need to look, right? And so it is a little bit harder on individuals with very dark skin, but there are areas that we can look at to see if they are cyanotic, okay? Because they will be blue everywhere, right? Okay, like this baby right here in the middle, their tongue is also very blue, right? So you're going to be able to see during a TED spell that they are very cyanotic in all those locations, okay? Okay. So we kind of already talked about the TED spells and what we're going to do for them, right? We're going to do fluid, oxygen, morphine, all of those things, right? So what does a kid with a TED spell actually look like?
So if we wanted to close, we're doing the endo one.
If we want the PDA to close, it's indomethacin.
If we wanted it open, it's
It's prostaglandin to keep it open. Okay. So this is obviously a kiddo who didn't have it done during that 3 to 12 month normal period, right? See how much more calm he looks? His color has improved, right, after those interventions.
Let me go back to the CS skin the first.
It's really hard to tell, but you can see that he's more cyanotic around his lips and everything, right? And just his overall like state, where he's very agitated. He's they've got him in that chest, knee to chest position. They've got the oxygen on him, right? His numbers aren't up there.
I've noticed, do they have pediatric ones in those like mobile ones like that?
Like that.
Yeah, because I've noticed the one I bought on Amazon, my daughter's fingers are too small even.
Oh,
But that looks pretty big.
No, I can't tell. Is that the oxygen in the heart rate, or is it backwards?
The SpO2 is on the left.
That one's the oxygen,
Yeah,
and that's the heart rate.
yeah, because if you look at it, there's a percentage on the left side.
Okay. Sure, you say so.
I'm not to take your word on that one.
Okay, and now you can see that his color has improved. Right. Okay. So, let's see. We kind of already talked about all of that. So, we're gonna make sure that they're getting 100% oxygen, either the face mask or not really blow by, because blow by is not really making sure that it's getting where it needs to go. That kid had a nasal cannula on. If they tolerate the nasal cannula, great. Otherwise, you might just have to put the mask on them. Again, giving that morphine to calm and reduce the pulmonary spasm. So it's kind of, it's almost like it's combating the fight or flight reflex, right? So when you have that response and your body releases a bunch of catecholamines, right? What happens within your system? What do you see?
Blood pressure, shunting inside the body.
Yeah, right? Your blood pressure goes up, your heart rate goes up, your respiratory rate goes up, right? Morphine blocks all of that, right? So that is why we give morphine, right? It is blocking that catecholamine response that's increasing all of those things to decrease and calm that child down. Cool? Okay. Some other things to take note. Obviously, these TED spells are a very rapid drop in their oxygen, right? A prolonged period of time or recurrent prolonged periods of time of decreased oxygen can cause a profound effect on the body, right? We could see that this has a neurologic effect, right? We could see that they have, lack of oxygen to the brain could cause some brain damage, right? If these are prolonged and recurrent over time, okay? All right, let's talk about digoxin. What do you know about it? Okay. So are there parameters to hold it, right? If our heart rate is less than certain levels, you have to monitor your potassium and your dig levels, right? Okay. Do we give it once a day or twice a day? Twice a day. Yes. Okay, so talking about administration parameters, right? We're gonna start there. So we talked about heart rate, right? It has to be above a certain level. We're gonna back up a little bit and make sure that we're calculating our doses, right? So you wanna make sure that you're calculating your dose precisely based on their weight or body surface area. We're gonna make sure that we administer it at regular 12-hour intervals, okay? It should be 12 hours apart. So educating the family, like what works best for you? Does a 7 and 7 time frame, an 8 and 8 time frame, or 9 and 9 time frame, something like that, right? What time does your child get up and what time do they go to bed, so that we can administer those as close to those times as possible, right? Because we want a 12-hour time period in between the two. We want to make sure that we're giving it 1 hour before a feed or before they eat, a meal or whatever, or 2 hours after. Why? Why is that piece important?
Yes.
It absolutely has to do with the absorption, right? So if DIG is given with food, it lowers its efficacy, right? And therefore then affects the absorption rate into the body and what's available to use, right? So then we see a lessened expected effect, right? We're not gonna get the expected effect if we give it the food because it's not working as well. Okay? Use a very calibrated dropper or syringe for accurate dosing. Again, making sure not to mix it with food or fluids, right? If they have to like swallow with a little bit of water or something, that's okay, but we really don't want anything other than that. Because then we're looking at the potential for a risk of an absorption issue, okay? If they miss a dose, it is okay for them to administer it if it's within a 4-hour window of the administration time. So if they're supposed to give it at 7 and they miss it, when can they give it? 11, up till 11 a.m., right? If it's beyond 11 a.m., they cannot give it because then it is too close to the next dose, right? So we're just gonna tell them, don't worry about that dose, just give the next dose, right? Are they gonna double up the next dose? No, absolutely not, right? Okay. What do you need to assess for prior to administration? So you said we need to assess for their heart rate, right? So for infants, we are going to hold it if it is lower than 90 to 110, right? For our, for like older toddler, preschool, school age-ish, we are gonna hold it if it is less than 70. And for our adolescents, we're gonna hold it if it's less than 60, right?
Infants, are you considering less than 12 months?
Less than 12 months. Yeah. Okay, so if they're less than 12, you're gonna hold it. If it's less than 90 to 110 for children, so like a year to adolescents, so 13-ish, we're gonna hold it if it's less than 70, and for adolescents, we're gonna hold it if it's less than 60, right? So we talked about adolescents are closely to that of an adult, right? And our adult hold rate is less than 60, right? So our adolescents are gonna be there as well, okay? We're gonna monitor their blood pressure, their electrolyte levels, specifically their potassium, right? We want to make sure that we're looking at those because digoxin can cause a hypoglycemic, right, effect. So if they are becoming dig toxic, they are going to have a hypokalemic result, okay? We're gonna monitor those dig levels. What?
Did you say glycemic or
Kalemic. Kalemic. We're gonna monitor those dig levels and monitor for signs of dig toxicity. Okay. When it comes to the lab values of any of those things, I'm not gonna test you on any of those. Okay, so you don't need to know like therapeutic dig level or anything like that one. Okay. You just need to know like what it affects. Right. It's there. So if they're showing signs of dig toxicity, how are they going to present?
They'll have auditory or non-auditory visual disturbance.
They could have visual disturbances. So our kiddos who can tell us that, they are going to say that they've got like halo effect or like rings that they can see around things. What about with their cardiac system? Their heart rate's going to be really low, right? They're going to be very bradycardic. Okay. They might have some arrhythmias, nausea, vomiting, maybe some diarrhea. They're going to say that they're feeling kind of drowsy. You might see that they're appearing a little bit more lethargic than normal, not really wanting to do anything. Okay. So kids are really good about spitting out their medications, right? So we want to make sure that like if they spit it out, was it that they were just spitting it out or did they actually like vomit it out, right? Because the vomiting could be a sign of dig toxicity. If they do spit it out, are we going to re-administer at that time frame? Why not? Because you don't know how much they spit out, right? You don't know how much they took, how much came back out, so we're just gonna move on and give them the next one, right? Okay. There are some foods to avoid with dig. Grapefruit juice, absolutely, right? Because it can increase dig levels by interfering with its metabolism. Licorice is another one. So natural licorice, not just the candy flavor, can cause hypokalemia. Also, ginseng and hawthorn can also affect DIGE. So it's really important that you ask your family, are you taking any sort of supplements of any kind, right? So if they're giving their kid any sort of supplements, especially like licorice, ginseng, hawthorn, whatever, we want to make sure so that they're not interfering with the DIGE administration, okay? High fiber foods can also decrease the absorption of digoxin and interfere that way, right? So then we're going to see a decrease of expected effect, right? It's not going to be doing what we want it to do. Okay. Cool. There is a video in there, it's about 11 minutes long, going over mastering the heart murmurs and what you need to know. That is more so like a good to know sort of thing. I'm not really gonna test you on like the specific types, not necessarily. Do you know the location of where you would hear one? Okay. Right. So like when it comes to like the ASD versus a PDA or BSD, like where you can hear it, right? So you're gonna hear the ASD along the sternal border further up, the BSD sternal border further down, your PDA, right? Like just kind of visualize where the anatomy of the heart is, right? And where you're gonna hear it. So your PDA is gonna be like mid-clavicular, and ASD sternal border, BSD sternal border, but we want, you know, ASD further up, BSD further down. And your coarctation, you can hear over here. Okay. Yep.
We need to know like the intercostal space and
Yeah.
mid-clavicular line, something.
Second, it's so like PDA and ASD are like second intercostal space, and then BSD is like the sixth intercostal space. But it's, I think in the book it actually just says left lower sternal border. Yeah, there's not really a intercostal space, but PDA and ASD are I think both at the second. But the PDA is mid-clavicular, while the ASD is at the sternal border. Okay. All right. Go ahead and take like a 5-minute break. I'll get into heart. We'll do heart failure and finish up the other two, and then we'll do our escape route.
Yeah.
Escape.